Hello, my name is Sarah, and today I'll be interpreting Susie's laboratory results using the lab interpretation decision tree. Susie is a 48-year-old female who is admitted with a new onset of chest pain. She has several cardiac risk factors, including smoking, vaping, minimal exercise, and a family history of heart disease. She is currently receiving IV normal saline and taking Lasix, so it's important to evaluate her laboratory results in relation to her symptoms and medical history. The first step in the interpretation process is determining whether each laboratory value is normal or abnormal. After comparing Susie's results with the normal reference ranges, I found that many of her labs were within normal limits, including her sodium, chloride, liver function tests, thyroid function tests, platelets, and several components of her complete blood count. While these normal values help rule out other conditions, the abnormal laboratory values provide the most important information about her condition. One of the most significant abnormal findings is Susie's troponin level. Her troponin increased from 0.12 to 0.35 to 0.5, showing a steady upward trend. Troponin is released when the heart muscle cells are damaged, so these rising levels strongly suggest ongoing heart muscle injury consistent with an acute myocardial infarction or a heart attack. Because of the finding, the patient would require continuous cardiac monitoring, serial ECGs, additional troponin measurements, and prompt medical treatment. Another important finding is her BNP level, which is 842. BNP is released when the heart is under increased pressure or strain. This significantly elevated result suggests heart failure or increased stress on the heart. As the nurse, I would closely monitor her lung sounds, oxygen saturation, intake and output, daily weights, and her response to Lasix therapy. Her potassium level is another critical finding. It decreased from 4.2 to 3.8 and then to 2.6, which is critically low. Since Susie is taking Lasix, this medication likely contributed to the potassium loss. Low potassium is especially dangerous in a patient with chest pain because it significantly increases the risk of life-threatening cardiac dysrhythmias. This value requires immediate notification of the provider, potassium replacement as ordered, continuous cardiac monitoring, and repeat laboratory testing. Her white blood cell count increased from 7,200 to 12,500 and then to 17,000, while her neutrophils are also increased. These results suggest an inflammatory response or possible infection that could be contributing to her overall condition. I would continue to monitor her temperature, assess for signs of infection, and review any additional diagnostic testing ordered by the provider. Susie's D-dimer also increased from 300 to 620. An elevated D-dimer does not diagnose a blood clot by itself, but it indicates that further testing may be needed to rule out conditions such as a pulmonary embolism or a deep vein thrombosis, especially in a patient presenting with chest pain. Her creatinine increased from 0.9 to 1.4, suggesting worsening kidney function or dehydration. Since she is receiving both Lasix and IV fluids, I would continue to monitor her kidney function, urine output, intake and output, and fluid balance. Her hemoglobin and hematocrit both showed a slight decrease over time. While these changes are mild, they may reduce the amount of oxygen delivered to her heart, which could worsen chest pain. I would continue to monitor these values and assess for signs of bleeding or worsening anemia. Finally, Susie's calcium score is 150, indicating moderate coronary artery plaque buildup. This supports underlying coronary artery disease and increases her risk for cardiac events. One of the most important parts of the interpretation process is looking at trends instead of individual values. In Susie's case, several laboratory values are worsening over time. Her troponin continues to rise, her potassium continues to fall, her white blood cell count continues to increase, and her creatinine is also increasing. These trends are more concerning than a single abnormal laboratory value because they suggest her condition is progressing. When I put all of Susie's laboratory findings together with her symptoms and history, the overall picture is most consistent with an acute cardiac event, likely an acute myocardial infarction. The elevated BNP suggests additional cardiac strain or heart failure, while the critically low potassium places her at high risk of a life-threatening dysrhythmia. The elevated D-dimer indicates that a blood clot should also be considered until it's ruled out. My nursing priorities would be to maintain continuous cardiac monitoring, obtain serial ECGs and troponin levels as ordered, replace potassium as prescribed, monitor electrolytes and kidney function, assess her chest pain frequently, monitor for dysrhythmias, monitor fluid status and oxygenation, and promptly notify the provider of any worsening conditions. Overall, Susie's laboratory results demonstrate the importance of evaluating laboratory trends alongside the patient's critical presentation. These findings support an acute cardiac event that requires close monitoring and prompt intervention.